Well, welcome everybody to today's ICMDA seminar. I'm Dr. Peter Saunders, the CEO of the International Christian Medical and Dental Association. And today's seminar is on the community health and development sector. What can COVID-19 teach us? And our speakers are Nathan Grills and Kaaren Mathias, who I'll introduce very shortly. This is the 11th in our series run by the ICMDA, which links groups of Christian doctors and dentists in 80 countries worldwide. So let me introduce our speakers. We have, first of all, Associate Professor Nathan Grills, who is a public health physician at the Nossal Institute for Global Health at the University of Melbourne in Australia. And he works on non-communicable diseases, public health and disability, largely in the context of community settings in India. He's established a number of community health and development projects in rural India and has also undertaken community work in India, Papua New Guinea, Fiji, Bangladesh, Nepal, and Kenya, Thailand, and Mozambique as well. So he's very well traveled. Nathan researches disability measurement and inclusion, and he has a personal experience of disability in caring for his 9-year-old daughter. In the past, he's extensively researched the role of faith-based organizations in responding to HIV and disability. And then our second speaker today is Kaaren Mathias. She's a public health physician from New Zealand who's also been living in India for the last 15 years. And over the last 10 years with the Emmanuel Hospital Association, she's led the mental health program in Burand, which is a partnership community mental health project in Uttarakhand state in India. And her research interests are youth resilience, participation, inclusion of people with mental distress, gender equity, health system strengthening, and really anything to do with community mental health. Karen's also a board member of Health Systems Global and holds adjunct research fellow positions in the universities of Otago, Umeå, and also Melbourne. So we're very honored to have you both today. And without further ado, I'll hand over to you, Nathan and Kaaren. Thank you.
Thank you, Peter. I'll start the presentation, then I'll hand over to Kaaren. Good morning, good afternoon, good evening, wherever you might be. I'm enjoying the little notes coming through, welcoming everybody to the presentation today. Just preface the presentation today by saying that there's a lot of experts out there and there's a lot of unknowns in the COVID-19 space. So these are our thoughts, I guess, but I would say there's a lot more known amongst the whole community out there, which is the beauty of community approaches, where I think a lot of the expertise lies with the people on the call. So I look forward to the discussion after the session as well. It's a pretty short time to try and cover what is probably the world's biggest challenge since World War II or the Great Depression. But I think for Kaaren and I, community development is a central part of that response. And I want to talk today about what we can learn from the current response and how that informs the community health and development sector. So we all know that we're facing a crisis. It's a dual crisis, I think. It's probably a crisis that has a health component, which we're all very aware of. And I think that we're seeing that the health impacts due to the virus affect the poor and the marginalised, the elderly, those with comorbidities are more severely affected. But also the effects of the containment itself is something that is becoming more evident now. The effects of the containment in terms of the economic impact and the flow and effect of that, access to healthcare, access to education, social and home life, and even spiritual well-being, access to churches and meeting together. But I think also to acknowledge that those effects of containment aren't just economic, but they have a very real impact on mortality and morbidity as well. So we won't talk about the response at a community level to COVID. That's covered in other sessions. I know Santosh Matthew mentioned it, and also the next session's also talking about that as well, Andrew Tompkins. So we won't talk about the particular health response. And I think probably a lot of it's known to all of us anyway in terms of the health side. I want to focus more on the development, the community development and the aid and development aspect and how COVID-19 has affected the community development sector. So what is clear for the sector is that this is unprecedented, and I guess we're all sick of that word, unprecedented. It's probably the most overused word of the last 3 months, along with a new normal. And I think we are probably going to be experiencing a new normal in the aid and development sector. The impacts have been quite massive, but I would argue that the impacts are both negative, and there's also some positive outcomes that we can learn. So I'll go through those quickly now. The negatives are probably clear to many of us who work in the aid and development sector. The funding has really flatlined and dipped now. There's an estimate in Australia, I know they're estimating that 30% of aid and development agencies will probably go under or enter mergers because there's a huge decrease in the amount of funding that is being given to charities. Also, their ability to fundraise has been significantly influenced. They can't fundraise face-to-face. I know personally some of our programs, a friend who's a Qantas pilot supports some of our work. Obviously, there's no income for him, and other business investors and fundraising and philanthropists are all affected. I think secondly, what we're seeing is an inward looking, which worries me, I think, both from a community perspective, from donors and governments, is looking inwards into our own community, into our own country. How can we look after ourselves? And that's become almost a bit more tribal, I think, in terms of not being aware of the outside or not caring about the outside so much. From the aid and development sector, that has meant that in a place where I'm from, Australia, a lot of the aid and development programs now are looking inward rather than actually thinking, how can we maintain our foreign aid budget? We've lost 2 grants that we had for disability work in North India because that's no longer a priority, and the Foreign Affairs Department has focused large lot of money on getting people back to Australia and supporting border control. So it's a difficult environment to work in. What we're also seeing is the NGO sector or the community health and development sector is really pivoting towards COVID, which I think is a risk of being the great distraction. There's an opportunity cost when we focus all our efforts and all our attention on one disease. We've seen that right across the current response, and people not being able to access normal health services, for example. But in the sector of aid and development, I think just looking at the other programs that are affected, when we pivot all of our funds and attention towards responding to COVID. I mean, education, there's 1.5 billion people in the education, kids or youth in the education right now, and they're all affected. Not to mention just the children themselves. There's the 3 million deaths have occurred of children since COVID began. There's been less than 20 deaths of children worldwide from COVID. So we're going to have a lot more people will die from our response to COVID than they will from a lot more children than from COVID itself. So a lot of those poverty reduction programs for children, immunisation programs have been affected. Immunisation rates have dropped, especially in low middle income countries. So it's a real risk that if we ignore those other programs, we're doing a good job and we stop funding them, we stop doing them, then it will lead to increased morbidity and mortality. Access during COVID has become very difficult. Practically, how do you get aid and programs to the field? People can't travel. I guess Australia is a victim of its own success in that the borders will remain closed for a long time, as they will in New Zealand. So, I'm stuck at home on my couch, not being able to get involved and be part of a response, which my heart wants to be. I think also the other negative is a lack of evidence and information. There's a lot of pressure to act very quickly and not a lot of evidence or information sort of to support that. But there's some positives for the health and development sector, which I want to touch on now. I think it's a really good trends. One of it is the idea of local empowerment. It's almost by force. It's been imposed upon us. Outsiders like us, we can't be involved in programs on the ground now. So we rely very much on our local workers, and they have to be empowered because they are the front now that has to be able to make decisions and has to be able to act, and they're probably best placed to act. Which leads to the other idea of navigation by judgment. There's a great book, if you haven't read it, called Navigation by Judgment by Dan Honig. It goes through the whole aid sector and says how it's more effective when we give the control of an aid and development program to the people at the local level. And I think that's happening now. We're forced to rely on people to navigate by judgment in our programs on the ground, which is a good thing. The use of ICT, of communication technology, is rapidly vamping up, even in low middle income settings. We had a board meeting last week with our program in North India. It was the most well-attended board meeting we've had, and also no one was late because there's no traffic. It was great that we can keep on meeting and keep on fellowshipping. So remote interactions can happen. It's much more difficult, but it's a time now that that can happen. If you want a little laugh, look at that YouTube link, which sort of outlines some of the difficulties in using Zoom. I won't go through that now. What we're seeing now is, I think, we're relying on a strength and assets-based approach, which is basically saying the community has the resources, they are capable of responding, and our role as an outsider is a facilitator of anything. And right now we are being forced to rely, and we want to rely, I guess, on the assets and the strengths of the community. It's a time also where we're forced to cooperate with the government. Some NGOs traditionally have been a bit out on their own, but this is a centralised response to the pandemic. A lot of the restrictions and the response is centralised. And they sort of have to be when you've got a pandemic that affects a whole country. So that's been a good thing. There's obviously difficulties in that as well if government you're working with has parts that are difficult to work with. But in some ways it is good to align with the approach of the central government. And that's, I guess, the whole Paris Declaration was very much how do we align our aid and development programs centrally rather than doing atomistic programs that are maybe less effective. I think it's a time of Kairos for us as Christians working in aid and development. It's a time where we can respond with love, we can respond to people's needs, and often our churches on the ground are playing that role, where outside players can't come in because of restrictions on travel or restrictions on access to certain communities. I think it's a key time for churches and people of faith to step up and to be able to respond and show their love to those in their communities. And that's been the case with a number of our programs in North India. I want to talk about listening to the community, and that's something I think we have learned in this current response. I want to hand over to Kaaren to speak about this and about a study we've been doing which involves listening to the community. I know this is a recurrent theme that's come up through some of the ICDMA seminars we've had. I know Santosh Matthew focused very much on this importance of listening to the community. So Kaaren, I might hand over to you to talk about a study that we've been involved in.
Kia ora koutou and namaste sabko. Nice to be able to talk. Nathan, do you want to flick to the next slide? I thought I'd mention some guiding principles that we've been trying to use in our work in North India and which are very relevant in this time of COVID. First is the idea that we really need to be attentive and listening closely to the community, and that involves listening to the quiet voices, the voices that you wouldn't hear. And I think, a great example of that is the blind man who was standing at the side of the road and calling out, "Jesus, Son of God, have mercy on me." And I'm sure in the crowd and hubbub of all that, it would have been easy to either just discount or disregard that, but also to keep going and say, "You've got time." But Jesus stops. And then interestingly, he says, "What do you want from me?" He doesn't assume that he immediately knew what that man needed, even though you would have thought a blind man would be obvious that what they wanted was sight. And so I think that's a really important starting place to be with community. And with COVID-19, just before this, I was on a Zoom call with the community mental health team I'm with, and we were talking about how to rejig our programs as India starts unlocking. And we all just stopped and said, but actually we don't know what the community needs anymore because things have changed. People have had 10 weeks in lockdown and we don't know. With new migrant labourers come, there's lots of changes. So if you want to go to the next slide, Nathan. The second guiding principle, which I guess is about listening to quiet voices, but is, looking for the least of these. And I think it's a really important theme right through the Bible, the priority for the poor and the priority for looking for the people on the edges. And Jesus did this very intentionally. People with leprosy, women, people from excluded ethnicities, people with mental illness, people with disabilities. people with stigmatizing jobs like tax collectors. And so I think this was an important thing, and is really important as we look at COVID to prioritize the people who are most disadvantaged. And if we go to the next slide of guiding principles, thanks Nathan. Linking to what Nathan had talked about, identifying and building on resources that are there, I think it's really important to act with available resources, but also look at each different context. There's not a plan that we can photocopy and march around the place where we work. We need to say, what does this place at this time need? And also not looking at deficits all the time. I think it's really easy to say, what are the needs, and not stop to say, but what are the resources here? In the community where we're working in slums in Derridune, because of the sort of patriarchy and the gender relations, most young women, before they get married, and now marriage is not so common to be under 20, there's about 3 or 4 years where young women have been educated but are living at home, and they often have a lot of discretionary time, and they're really great as health volunteers. So that's a resource in urban Derridune, but in rural areas they've got lower education and they get married younger, so that's not there. So I'll go to the next slide. So I thought I'd just really briefly talk about a study which we're literally in the thick of. So Nathan and I are working with team members in India, and I won't go into a lot of detail about the pernickety aspects of the study, but I just think it sort of illustrates these 3 principles. So the study questions we're looking at are, what are the acute impacts of the COVID crisis on disadvantaged community members? And what are the practices and factors that increase coping and resilience? And so we're looking for assets, coping and resilience, as well as looking at negative impacts. And we're particularly selecting people who are disadvantaged on multiple axes. So people with disabilities in a rural area, people in slums with mental health problems, and widows who were also largely illiterate. You can go to the next slide. Just really briefly, if you haven't had the blessing of visiting Uttarakhand, it's one of the most beautiful states in North India. 10 million people. It's poorer than the average in India. For the 10 million people, there's 7 government psychiatrists. The people with disabilities, the majority have no access to rehab or supportive devices. Widows get a benefit of around 25 Australian dollars a month. And it's really spiraling out of control. So it's gone from 90 cases to, I think it's actually over 1,000 now in the last 7 days. So the COVID situation is deteriorating quickly. But obviously with 10 million people, there's still the huge majority are well. That's fine, we'll go to the next slide. So we did in-depth interviews with these 24 people, each in really different situations. Some we could do face-to-face, and some we did by phone. It was all in the first 2 weeks of May. And what we found is I'm just going to focus on 3 or 4 of the key findings, but the othering, the deep and growing mistrust of people different to ourselves was really apparent. It was described by Hindu people in slums describing their Muslim neighbors, and vice versa. And it was particularly observed by Hindu and Muslim. And there's been a lot of civil and growing unrest. But this statement in the middle of this quote here, this is a verbatim quote saying, people from the Muslim community are not following the rules. And there's a change in our relations since COVID. Earlier, they would say, Tum meri dharam ki behin ho, you're my sister in faith, and now they're ready to run bulldozers over our homes. And obviously this is someone's perception, but it gives this real sense of the social distancing leading to more stigma, more discrimination, and more mistrust. And I think that's a really important finding that is actually, I've read in Guardian and other reports. So I think that's a really important place for Christians to act and to recognize that each person is made in the image of God. Go to the next slide. Another big impact, which isn't surprising, but it's really huge. This is not something that people feel like they've got a grasp on. It's a new problem, and it's caught a lot of people unawares. Just 2 days before the Indian lockdown was declared, I was in a small village, and we were doing COVID awareness, trying to encourage hand washing and social distancing. And all the women in the group of about 15 women I was talking with were really wanting to talk about was a asteroid that was going to be perhaps hitting the Earth on the 29th of April. And I did need to listen to them. That was their primary concern, but it's very overwhelming. And this quote here, captures just how vast, we've all been, utterly drenched in COVID media. And some of us are trying to limit how much we watch, but saying we've forgotten about all other diseases. We can only recall corona now. There are no more diseases like dengue and malaria. Now we have one disease and all the others have vanished. And just the sense of, and this is actually the reality also, that a lot of people haven't been able to access care if they're experiencing, severe illness from other diseases. So it's very overwhelming. And then going to the next slide. The people who are disadvantaged on multiple axes, and this story here is, this quote is from a woman who is illiterate and is Dalit, or from the most oppressed caste. And she said that for a whole week, because there've been government rice handouts, but no pulses or vegetables. And she said, well, we've been eating fried rice cakes and drinking tea, but we're pretty hungry. And describing how she went to the market with a single rupee, and managed to borrow 200 rupees and took more items on credit. And I think, that, actual food insecurity and hunger just shouldn't be the case in lands where there is enough food for everyone, but this has disrupted and made people who are vulnerable more vulnerable. Go to the next slide. And so it's important to not only look at how grim things are. There's some really important accounts of coping and people using what's around them for solace. And I really love mountains and wild, beautiful places. And so I was very happy to find that this is also a form of solace. And people saying, we're going out in the fields and going to the jungle. And when you take goats grazing, you don't remember that corona is happening. And I love that image. But there's also some other really good examples. A woman in the slums whose daughter is a wheelchair user described how there was a small injured bird, and she said that bird has kept my children happy every day, all day. They're out looking for worms and they're feeding the bird. And so I think that God's creation is just a huge resource, and I think for mental health and well-being, it's really important to think of creative ways to keep engaging with it. Go to the next slide. And then another example of coping is people who are taking in new practices, taking perspectives. This quote here is from a man who had a high spinal injury 2 years earlier, and he sort of is saying, well, I can say that this situation isn't doing only bad to me, but it's the same for everyone. I'm not alone, and I'm sure many people out there are going through the same thing. And actually, a lot of people drawing consolation from the fact that the Amir Desh, the rich countries, are suffering. And it may be that India looks quite possibly going to catch up with the US, and which no one's wanting to be up on the league tables on this, but there is a sense that everyone is suffering, and that's been a source of solace. Prayers were also, and increased practice of devotions have been mentioned very frequently in this research data. And the next slide. And so I guess that thinking about COVID and community development, thinking about these three principles that I mentioned, and looking at these quite scary graphs. India's nearly hit 10,000 yesterday in cases, and in many countries we can see. I know that Brazil and Russia are particularly high numbers, but Bangladesh, Pakistan are climbing very fast. And I guess that things have been relatively quiet in Africa, and I really pray that they can remain so. But there are some invitations, and I think following principles that ensure that we really try to make our responses grounded in the Gospels and in the examples of Jesus are a good start. I think there's one more slide for me, Nathan. So I've just put some questions because this is an incredibly interesting dichotomy of where some of us have never been so local in our lives. I spent a lot of the lockdown in a small house in a small area with 60 other people, and I've never been in one place for so long for years. I don't know if I ever have. And so it's very local, but it's also incredibly global, and the whole pandemic is happening. So I was thinking about, how do we design projects? Are we including and inviting to be at the desk in the design phase, in the funding proposal writing phase, people who are affected, people with lived experience? Are we using methods as we go about our implementation plans to making sure we've got community representation? When we talk about including the least of these, is our team, how much, who are the leaders? Are they male or female? How much opportunity do we give for leadership to people who come from and live in communities? How much do we look for the existing assets and build on them rather than bringing in a program that's been run elsewhere? I think the way that we set up the governance of our projects is really important. And in COVID, there'll be new streams of funding, and it's an opportunity for us to really say, using the model that Nathan was alluding to, how do we make sure that decisions made in the field and the budget setting is done most of all at the ground level, where they really know what the needs and realities are? How do we make sure that we focus on the least of these and in our outcome indicators? I could talk about this at great length, but I think I'm hoping that gives enough of an outline, and I'll hand over to Nathan to just tie this up a bit more. Thanks, Nathan.
Thanks, Kaaren. I want to summarize a little bit of what Kaaren said and just the learnings that we have encountered as we go through today's lecture. I think the aid and development sector has to look very differently and more creatively in terms of areas like project management, the operation and functioning of a project, even fundraising. These things have to be rethought. I think we can't rely on the traditional business as normal approach. So I think that's pretty clear. I think there's a danger of imposing outside ideas. It's almost neo-colonial. We're seeing that in the responses to COVID right now. A response to COVID in America is very different to a response to COVID in India, let alone in rural India in a village where this research was done that Karen's referred to. So the importance of actually not just automatically applying what we've learned from elsewhere, but also taking into account the age structure, the poverty state, the health system, it would mean that we have a very different response. That's where community development does teach us that importance of a local response. The model of primary and community healthcare has never been more relevant than now, especially in the current situation where there's been a lockdown. Karen's referred to the volunteers that we've been working with Project Buran's disability workers. It's not therapists or doctors that are going in there, relying very much on our primary healthcare workers or disability workers or mental health care workers who are locally based, who know the context, who are able to keep on responding. So I think, we're learning now that we can't rely on a necessarily international system. We have to rely on a local primary healthcare system. I think maintaining a focus on the poor and marginalised and disadvantaged has come through very clearly today from what Kaaren said, and just that's probably a focus. A lot of the community health and development programs that a number of us are involved in is that focus. But it seems that often it is the poorest and the most vulnerable and maybe children that are going to suffer in this current environment. And I think we risk in our responses robbing the poor and robbing the most marginalised to protect the rich and kind of others who don't have the same sort of vulnerabilities that these groups do. So with that in mind, I think we have to be very careful not abandoning existing projects, which I spoke to a bit before. the opportunity cost of doing that is going to be massive if we do, in terms of NCD burden, maternal child health, access to immunisations, just education in its very basic education is associated with decreased maternal mortality rates. So if we're going to drop education and that's all affected as well, what's the effect of that even on maternal mortality? But I just want to finish by saying that I think as Christian doctors, dentists, health workers, we have a message of hope in the midst of fear, a message of hope and peace. And I think we have that hope in Christ, which does bring us a bigger understanding of what we're doing. And we know that we're loved, and we know we don't suffer alone, that he is beside us. I think we know that we have a God of purpose. Often that's hard to see in the pandemic, and it's hard to identify what God is doing, but we do have a God of purpose who we know is at work, even in these very difficult times. We know that he can deliver us, even in the face of death and in facing a pandemic, that we know that he is in control. So I'll finish there. I wanted to leave some time to hear from the experts out there, where there's two people with our ideas, but it'd be great to hear more from you, and if you could share your ideas and questions and answers. Thank you.
Thank you very much, Nathan and Kaaren. That was amazing in the limited time that you have to give us that overview, not just from a perspective of great wisdom about community health, but also as Christian believers, blending it all through with what we can learn from the scriptures. We've got some great questions coming in, so I'll start putting those to you. Nathan, first of all, you've mentioned a lot about the challenges of financing in this new COVID environment and the fact that a lot of funding streams are drying up. What are your views on how to increase financing in the NGO sector by use of perhaps new financial solutions? Where should we be looking?
Yeah, I think it's probably accelerating a move that was already happening, in that we were seeing that digital fundraising platforms are being increasingly used in fundraising. Crowdfunding is a great example of that. And I think we'll be relying more on these type of approaches. And not to say that traditional donors are stopping giving, and I think we've been really blessed in some of our response to have people that have actually probably increased their giving to help look after the most needy in these times that have been very difficult. But I think there will be an increased move to digital. There's some really good resources out there online, which I can share with you, and you can share around after, that have some really good just short presentations on this with experts in the fundraising space. I'm not an expert in that fundraising space, but I think also from what Kaaren and I were saying, there's going to have to be an increased reliance on local resources where they're available, both at the community level, but also local philanthropy in a place like India, and maybe less reliance internationally. But definitely, yes, I think digital platforms will be key. We can't meet face to face. We can't do fundraisers. The risk would be that smaller NGOs start to try and do fundraising activity online, and it doesn't work. It's a difficult intermediate to get right.
Yeah, and sadly, a lot of NGOs have responded by putting staff on furlough during this period when perhaps they're most needed. The next question is, you mentioned the importance of working with government where that's possible, and it's a great opportunity, but also a challenge, especially if we want to focus on the most vulnerable, and the government priorities might not always be those priorities. What do we do in situations where the government seems to have no clear strategy and is not always accountable, even though funds have to be channeled through them? Any thoughts from both of you on from your vast experience of how to deal with those kind of issues?
I kind of start maybe by saying that the government, I think even in a place like India, has been really good working alongside them. So I think at the local level, there's been a realization they don't know what to do. How do we respond to such the huge needs that are all suddenly appeared? And I think there's been a very willingness to cooperate with a lot of the NGOs with a common purpose of trying to reach those who are marginalized and get services out there. So it's probably in some ways been positive. There's been much more cooperation than traditionally, perhaps, I've found from the reports from the field. But I think also, we talk about a central government level that's very far removed from the field. There's often that divide. In a lot of countries we work in. But what's the alternative right now? I mean, you have to be able to work alongside. I think that's a challenge for FBOs, faith-based organisations, these environments, is working out ways to do that, and in a respectful way of continuing to do the things that are important to us, like responding to the most needy, but be able to work alongside government. I think maybe Kaaren Burans has worked quite closely with the government in Witwatersrand. Maybe you can talk about that a bit.
Yeah, I was just going to mention we've been actually pleasantly surprised in the COVID outbreak. We were involved in relief operations to support particularly migrant labourers who didn't have paperwork and ID to warrant being given the government rations. And we were told that we have to do all ration distribution with police, and I was feeling very sceptical about that. And the police were actually very engaged, and we said to them, look, we can take you to the houses of people we know with disabilities, migrant labourers, we can, and if you will verify that they are hungry and needy, can they also access rations? And so we actually got about another, I think it was 80 families onto the regular ration distribution, which is supposed to be for local residents, because they trusted us as an NGO that these were high need families. So I think we just have to keep trying, and I think we might find it ourselves surprised. And they invited our staff to help in their gender-based violence counselling centre, because they just were so overwhelmed with numbers, and they said we already had a relationship, and that was also valuable. So they said, please, can you have your staff coming in and counselling, because we're completely overwhelmed with violence cases. So I think it's a good, and I think that will lead further. So I think that's a good opportunity.
Yeah, those are some great stories, and really encouraging too. Now, you talked about both being stuck at home and working with teams on the field and not being able to be there, and the importance of empowering local communities. Kaaren, the next question is how do you do teams differently when it comes to the online space? And have you found this to be an opportunity on the field to connect with people abroad, perhaps who you wouldn't normally connect with? Maybe some stories on that too, to illustrate what you're about to say.
Yeah, well, it has actually been really interesting. There's been quite a learning curve for our team. Previously, I guess the more senior staff, we had all used Skype. Skype seems to have kind of gone off the face of the earth in 2 months flat, but it's a separate issue. But yeah, so we'd been using Skype, and then we did our EHA, the Emmanuel Hospital Association annual reporting using Teams, the Microsoft platform. And you know, actually, I'm pretty sure we're going to now use this at least a lot more. It's been a huge time saving. It's 2 or 3 days travel by train, usually for all our teams from around North India to meet together and do our annual reporting and best practice meetings. And instead, we did an hour and a half every morning over a 2.5 week period, which was far more tolerable. No one minded giving attention for an hour and a half, and often reporting meetings by 5 p.m. everyone's quietly slipped off to the bazaar for a chai. So yeah, so I think this was like, we never would have been pushed into this. And even in our community workers, 4G is really quite widely used across India. And so we got all our community workers. WhatsApp expanded to having 8 users. And so we've been having team meetings with, I've been able to get 5 community workers online and say, tell me what's happening. Let's work out what we do next. So I think it's actually been it's really pushed us. And I think it's leading to some really good outcomes. I wouldn't say it's all easy, but it's been really positive.
Excellent. Nathan, one for you now. You mentioned the importance of a time of Kairos as a positive aspect for community health and development in the COVID time. Would you be able to unpack that a bit more for us? What do you mean by Kairos, and how can it be applied and best used?
Yeah, I mean, Kairos basically is a Greek word that refers to a time of opportunity, and more of a supernatural idea of God providing an opportunity for us. And I think for the Christian development sector, sometimes we're inclined to do programs and activities and form NGOs, but actually how do we involve the church and people who are on the ground, who are people of faith, that we should be empowering to respond? And I think in the current context where you don't have the big NGOs, a lot of them typically right now don't have access to the field. They aren't in the field. And in many of the contexts that we're working in Africa or in other places where the church is strong, then I think we're going to have to rely, and we should be relying more on the local church to be involved in providing services, in providing relief, in helping to encourage those that are on the front line. So I think it's a time for the church to sort of step up and take its role and play a more central role in responding to the needs locally, rather than it being considered as a development program done from the outside or done outside the church. So I'd hope it's a time of Kairos for the church and for Christians themselves to step up in the absence of the bigger players that might be limited in their access to the community because of restrictions on travel or budget issues. But it'll be different in every context, Peter, and I think that's pretty clear depending on where people of faith are based and how strong the church is and what role it plays.
Yeah. If you just joined us, we're talking to Nathan Grills and Kaaren Mathias about what we can learn in community health and development from the COVID crisis. Please do type your questions into the Q&A and upvote the ones that you'd like asked, and we'll try to get to as many as we can before we close the session. Nathan, you mentioned the church, and I wonder, that's our next question for both of you. How can the church help the poor specifically to serve better on this issue? Perhaps with some examples that you've seen of good practice and not so good practice.
Yeah, and Kaaren will have insights here as well. But I think in the time of COVID, social distancing is an important thing to maintain. So by loving someone too close, you can cause more harm. So it's different in how we go about responding. There's an excellent issue in the Christian Journal for Global Health that has a number of examples about what can be done practically by Christians at a community level. For me, very practically in terms of the disability programs you run, the responses aren't always expensive. Often it requires just being able to advocate for someone who has a disability who needs a certificate to access a service, or going with them to a hospital, or advocating for them to actually have the right to access a pension. So a lot of things don't require much expense. It requires maybe time and loving that person rather than actually having professional expertise. It's just walking alongside them and encouraging them. So a lot of our work with Christian organisations and local churches is helping those churches to play that role in the disability space in India. So yeah, obviously in providing healthcare right now is more difficult. And I think if you have a neighbour in the situation where there's not access to medicines now, that they're vulnerable, or they're a widow, or they don't have access to a phone, I mean, just being there for them within the restraints of what's appropriate now in terms of social distancing, but where you can, just being able to check in on them, to offer to get access to some medicines for them, which we've been doing through our programs and local workers, that people with essential medicines haven't been able to get access to them just because they can't travel. And they can't get people to bring them in because the roads are restricted in terms of travel. So just very basic, just being able to ask people, what are your needs and how can we be involved in helping you, especially of the most vulnerable and marginalised. But Kaaren?
Kaaren, do you want to add to that?
Yeah.
What ways for the local church to help specifically?
I think that this is where relationships are really important, and where there's existing relationships, you can just do an incredible amount by phone and checking in with people and how they're feeling. So even when we were doing this COVID research, a lot of, the vast majority of participants were so thankful to be able to just talk about how they were feeling with an interested, attentive listener. So I think there's a huge value in offering a listening ear, and I've been able to do that with neighbours, keeping a respectful 2 metre difference, like people just around where you live, but I think also by phone. So I think that's an opportunity for all Christians. But there's also, surprising opportunities. There's a church in Mussoorie in Uttarakhand, in the town where I've been living, and we just suddenly needed a big room where we could store lots of rice and bag things up ready for distribution. And this church just immediately said, sure, it's fine. We've already got mice and rats, so it doesn't matter. Give them a little bit more to eat and but use our room. And so just being very willing to use resources. And I've seen a few churches who have kind of like, please don't cross the boundary because we don't want anyone with COVID in our property. But I think it's the chances of that are pretty slim, and that opening up a room is a very useful thing.
The next question from Lee in Nepal is about that fear, and the question: how are your community-based hygiene, health, and social distancing messages being communicated, and is there good evidence of uptake? Lee mentions that in Nepal, health workers are often terrified of asymptomatic carriers among patients, but also among staff. And if this educator group is finding it so challenging to take these messages on, what's the hope for lower educated communities? That's the question. So how have you found messaging is being taken up, and how's it best delivered?
I'll jump in first. We've never had such attentive community audiences in giving health promotion messages, and particularly the first few weeks. We've had a group of community volunteers, young people under the age of 22, who were running small kind of corner meetings on awareness around social distancing and hand washing. And so we're using practical examples. We had about 100 mils of water, and we were doing like who can wash their hands well, that everyone thinks they wash them well with 100 mils of water, because we're really keen to get a message across that you don't have to have a tap and deplete your small water supply. So practical measures like that. I think just our staff were really, really scared at first. And so, we made sure that people had masks and knew the guidelines. And we've just said, you don't need to go into anyone's house. If you can't talk at the doorstep, that's fine, go to the next house. So we're not asking people to put themselves at risk. So, but then also reassuring them so that unreasonable or not without a good basis fears can be addressed. But some of the staff who have older parents at home, we've just said, that's fine, you guys don't have to go in the community. We don't want to put your family members at risk. So we've kind of tried to create evidence-based guidelines to keep everyone feeling safe.
Thank you. Nathan, anything to add?
Yeah, no, I think that's very helpful. I think just being aware of the risk and risk communication is important too. Being fearful of your kids actually having a bad outcome from COVID is not rational. There's no chance, or very, very little chance of them dying from COVID. Definitely dying from diarrhea or pneumonia or lack of immunizations. But I think help people understand that their kids are safe. The less than 20 that have died out of 6 million infections. We know that now. So I think, but yeah, being also aware of the elderly people they might be living with, like Kaaren suggested. But even a health worker of my age, I'm the average health worker age in Australia, 43. I just did some modelling from the current mortality statistics, and my risk is still very, very low of dying from COVID. In Australia, there's been no deaths under 55. In America, the average age of death is around 80, and most people with comorbidities. So I think for the average young, health worker in India, which the average age is about 38, the risk to them is very, very, very minimal. The risk to their families can be significant, and that's where Kaaren suggested if there's an elderly family member taking precautions and making sure that that person is safely isolated and not interacting with that health worker might be wise. But a lot of it's about risk communication. I think the media doesn't help. I think encouraging people not to be binging on the media, they fueling the fear, I guess. It gets people interested in their media, in their television station, but it doesn't help people sort of be able to balance the reality of what's happening and the risk that's actually is there for them.
That's very helpful and wise, and really puts it into perspective. What the media often tends to do is to highlight the outlier cases. So if a young person dies, then it's national headlines, but we're missing the fact that it's vulnerable elderly people primarily who are at risk. So thank you for that. The next question here is there a role for private business and social entrepreneurship in community health and development in the COVID area? And perhaps if you've seen some examples of that. Now, which one of you wants to take that? Feel free to jump in.
I mean, I can just mention briefly. I think that enterprising and social business that is hasn't got extortion as its kind of primary motive. I'm sure there are useful things and useful contributions. But I think that business, by definition, needing to make profit just needs to be, I guess that I feel like there needs to be some strong governance mechanisms that is actually serving the needs and that the profit margins are not unreasonable. And for example, one group had gone into the valley where we work and was selling masks to families, surgical masks, for about 400 rupees a mask, and you know that's 2 weeks food for a person. And so that is completely unreasonable thing to do. And so, yeah, I think it's really important to be moderate in the profit aspirations.
I wouldn't add much.
Yeah, carry on, Nathan. Yeah.
I wasn't going to add much. I was just going to say, I think that there is a role and it has to be carefully thought through, particularly in, we're seeing that right now and trying to get access to basic PPE for the health system. In India, they need to work with the private industry, and it can be effectively done if we monitor it and regulate it, I think. Yeah.
Thank you. One more for you, Kaaren. This might have to be our last question, but you mentioned about the increasing gender-based violence cases during the epidemic. What do you think is fueling this, and how can we respond?
I think gender-based violence, there's a lot of things fueling it, and probably a very basic thing is the value that is placed on males and disadvantage that is faced by females, so that the whole power relations and families. But in the particular setting of COVID, I think that hierarchy, we talked about othering being more frequently happening, and I think social hierarchies are often accentuated in crisis. People who have more decision-making power often stride forward, and so I think that people who are vulnerable are more at risk. So, and I think it's also just a very difficult thing to be living in a small room with 7 other people who, and it's getting pretty hot in India and in many other places. We're heading into a pretty hot part of summer. So I think it's just stressful. It's hot. People are hungry. They're bored, and your normal ways of seeing your friends aren't there. So I think there's a lot of reasons why they've increased, and I think responses really need to kind of look at more. This is why the lockdown was so unhelpful, as it wasn't humane, and it didn't give people strategies to address like core needs like income. So I think countries that are recognizing that food is a higher priority than the risk of COVID for nearly everyone who is very, very poor, giving opportunity to go outside and giving messages like saying you can go for a walk, keep 2 meters from other people, instead of keeping people locked in houses, can make a huge difference to well-being. But yeah, the big thing is, I would say, addressing patriarchy.
Lovely, thank you very much. We loved your constant allusions all the way through to Scripture and to the example of Jesus and the principles which are so much earthed in the Christian faith, listening closely to the community, looking for the least of these, acting with the available resources and being good stewards. Just maybe a final quick question to you both. What's given you the most joy over the last few months in dealing with the community in this crisis?
I think maybe it'd be the creativity of some of our workers in actually being able to engage with the community. And that's one of the questions there from Genderbased and from Nepal as well. It's very difficult to do community mobilisation right now, given lockdowns are ongoing. But most people have access to a phone now, and just some of our staff that are just regularly ringing up, especially vulnerable people in the community, just to see how they're doing and how they can help and how they can be able to, encourage them, and just the opportunity to pray with them as well. A lot of people just want that encouragement in this time. You can't do much else, but being able to pray with them or pray for them is just really powerful as well. But I think also trying to do that creativity is also helping the local services, giving masks to the local police officers and the pradhans and the village leaders, and serving the whole community rather than being focused just on serving the most marginalized. Because right now I think everyone's struggling and the whole community is really finding it difficult. So our programs have actually been focusing, I think, and the people that could go to the village in the lockdowns, they have permission to, actually serving everybody who's equally finding it very difficult right now. There's a lot of fear, a lot of uncertainty across the whole population, not just those who are the poorest. So yeah, I've enjoyed seeing the creativity of our workers. I think it's brought me the most joy.
And for you, Kaaren?
I just was very touched by an example. It was a 18-year-old Muslim woman who joined together with one of our Hindu health volunteers, and then they worked in the Sikh Gurudwara and crowdsourced food by going knocking door to door in the slum where they were, and fed, it was like 180 people over one meal a day for a week. And for me, it was just great seeing these women taking initiative. I don't think there's any Christians living in that area, but I guess just seeing that hope. Thanks.
Thank you so much. Well, I'm afraid that's all we've got time for this morning. We could go on and on because your talks have generated so many questions and really got people thinking. So we're incredibly grateful to you both for that. There's actually one question here for ICMDA, which says, in times like this, when there are opportunities to do things at the strategic level, particularly for organizations like ICMDA, have we considered centralized marketing or centralized technology departments? Well, ICMDA central office is quite small, but of course we have had to change our strategy completely because of all the conferences and events that have been cancelled. I think I had 10 overseas trips cancelled altogether, and we're focused very much on central technology approaches, resourcing our field workers, and of course this webinar series is a big part of that. We would never have started it had we not had COVID. We would never be putting out our COVID bulletin or started a blog or had access to resources on the website and so on. So I think it's a case of trying to pivot and adapt to the situation. And we're very grateful for all of you coming to the webinar today. So thank you again for joining us. Thank you again, Nathan and Kaaren, for your time and your expertise and the way you've answered all the questions. God bless you all, and hope to see you again shortly on ICMDA webinars. Thank you.
Thank you, Peter.
Thanks.